Okay, we wanted to introduce our panelists for this evening. We have pharmacist Walt Leza, Fayette County Coroner Dr. Philip Riley, Steve Contaxis from the Fayette County Drug Task Force, Attorney Jack Purcell, District Attorney Jack Hennicks, Dr. Robert Woolhandler, Treatment Clinical Elaine Stano, and we have two recovery people, Bill and Brendan. So we do have a number of questions for the panelists, and the only thing that I would say is try and be as brief as you can, because we do want to give everybody, all the panelists, the opportunity to speak, and also too we do want to have allow anybody in the audience that has any questions, and we want to try and get everybody home at a decent time too. Thank God there's no pens on tonight or anything, so we could all rest easy with that. But you know, and I don't have a cane or anything like that, but I do have a clock here, and I'll be watching it. So just urge it, you know, 2-3 minutes. That'll be more than enough. So we'll start out. I'll be asking the questions, and we'll go around to the panelists. First question is for Walt Leza. What is a prescription drug, and are they harmful?
Well, first of all, I'd like to thank Fayette County Drug and Alcohol for having me on this panel. I feel honored to be with such distinguished people on this panel. Secondly, I'd like to thank Representative Kula and her fellow legislators for supporting so many issues relating to pharmacy. Trust me, it doesn't go unnoticed. We do appreciate it. So thank you very much. As far as a prescription drug, it's quite simple. It's a drug that requires a prescription. Really, that's it. But it's not very difficult. But the things that go along with it are, there are different schedules to drugs. There are non-scheduled drugs, which are the more common ones, drugs that are used for diabetes, high blood pressure, epilepsy. Then you have these scheduled drugs, which go from Schedule 2 through 5. The lower schedule, starting with Schedule 2, are drugs like oxycodone, OxyContin, move on to all the way up to Schedule 5, which are some of the codeine-containing cough syrups and things like that. The lower the schedule of the drug, the more addictive its potential is. So, if taken properly, are these drugs dangerous? No, they're not. If you're taking a medication for the appropriate reason and taking it properly, you should have no ill effects. Obviously, everything can have a side effect, but are they dangerous? Truly not. Now, when you don't need a medication, and let's say you are taking it more for pleasure, obviously it's going to require higher doses. Can those cause problems? Absolutely. Can they cause addiction? Absolutely. They can cause difficulty in breathing, respiratory depression. So is it an issue? No doubt. As Secretary Tennis said, just small amounts of medications can cause problems with people because they have an addictive potential themselves. Because of their biological makeup, they're more apt to become addicted to a drug than somebody else. We've actually seen people who are elderly that go through a knee replacement or a hip replacement. They're on a medication for a short period of time. And then upon discontinuation that medication, next thing you know, they're going through the delirium tremors and they're starting to have withdrawal effects. So can it happen quickly? It can, absolutely. So are they dangerous? Once again, if used correctly, should have no ill effects. When they're misused, very, very dangerous, as to which I'm sure you're going to hear from our fellow panelists. So.
Okay, thank you very much.
Can I ask a question?
Sure.
Walt, could you talk about tramadol and why it's not controlled, and even though it's an opiate?
You know, truthfully, Doctor, I don't know why it's not controlled. To be totally honest with you, it should be. I'm a big believer that tramadol should be a scheduled drug, and also I think hydrocodone should be a Schedule 2. instead of a Schedule 3. Why things are scheduled the way they are, it's beyond me. Another good one I can give you is if you take a look at Furanol, which is used for headaches, it's a combination of butalbital, aspirin, and caffeine. It is considered a scheduled substance. If you take a look at Furacet, which is a combination of butalbital, acetaminophen, and caffeine, so the difference is only Tylenol compared to aspirin, that one is not scheduled. Well, neither aspirin nor Tylenol are addictive. What on earth would make the Furacet not scheduled?
Right.
The rationale is beyond me, truthfully.
And that's another one. And the reason I bring it up is because so many times through my practice day to day, people come in and they're on tramadol. The doctors told them it's non-addicting. So I want people to be aware of that it is addicting. It is a centrally acting opiate. This goes to some of our work about doctors need education. Doctors get very little education on drug and alcohol. I went through education a long time ago, but when I talk to the young guys, they get as much as me or less. So a lot of times when a doctor tells a patient it's not addicting, when it actually is addicting, that's why I threw it. I just wanted that word to be out there. Tramadol is an opiate.
Yes,
beware.
Okay, thank you very much. Our next question is for Dr. Riley. What are the most commonly prescribed medications that are being used for pain management?
Well, thank you for the opportunity. If we're looking at pure pain from whatever cause, an old standby, well, Tylenol with codeine. No, Tylenol didn't mean that much. It's very mild for pain, but it's a codeine, and it's been used for years. It hasn't led to a big addictive problem because very few of us would take a lot of codeine because you get sick. We've all had codeine cough syrup, and you get a queasy stomach and nausea, so it never really evolved. Problem was it didn't have the potency, so that we moved up to the short-acting, fast-acting hydrocodone. And I even put that in a cough syrup, and it really works for cough, really works. But is addictive. It's a narcotic analgesic, and the nuisance factor, it may last only 4 hours, maybe 6. You'd like to see it last 8. So they were looking and searching for, well, this poor person that has this pain from terrible fractures, and it's only going to last 4 hours. We're treating this round the clock, 4 times a day and so forth. So couldn't we invent a long-acting? And we did. The OxyContin combinations that last 12 hours or so. And that's a nice convenience, twice-a-day dosing and so forth. Very potent, taken at the right dose, and clearly at every 12 hours and not more, you wouldn't get into trouble. But imagine if you took an extra one, whether confused, forgetful, or just didn't think the first one worked. You're now dealing with a 12-hour delivery of medication shingled onto it, so that carried with it a convenience, and the downside, this immense threat of a potential error and overdosing innocently on that, whether I had terrible pain from my hip, or if I were looking for a high, not using it illicitly because I had the source. So then we thought, well, we're even smarter, we'll come up with a patch, and a patch that had 72 hours of continuous pain suppression with high blood levels of a narcotic analgesic that was first invented as an anesthesia agent to put you out for surgery. Fentanyl, correct, Walt? Correct. And here you have that, and it took us a while, and what saved us was the media. It turns out that 72 hours, someone looking for a high would bite into the patch and suck through the whole patch gel out and have 72 hours of narcotic analgesic in the system in minutes, and frequently would be dead by the time they would hit the floor. So we only recently wised up, that's ridiculous, but when we had the clusters of deaths from the fentanyl patches, the media helped us out, pointing out the danger, and the illicit users got smart and stopped doing that, knowing that it's so powerful, and the industry within the past year designed a patch. Can't happen. Correct, Walt? It delivers it out, so we have those 3 levels of pain. Tylenol with codeine, safe, may not handle all your pain. The short-acting, we have the nuisance, but it doesn't have the threat of an accident if you that the long-acting 12-hour pills, should you innocently take an extra one, and this is where, again, we would turn, however we get the message out. That convenience has a built-in serious threat that we're accepting that convenience of dosing. Imagine passing it out with 100 patients in a nursing facility. Now you only pass out twice daily, the manpower issues and so forth. But we pay a price, and we will see inadvertent deaths, whether it's an illicit user or authentic pain. The patches may come down the road to solve the problem in being, in a sense, foolproof. So the patch is on, off, and then a new one goes on in 3 days. Obviously, if you put 2 patches on at the same time or 3, we're looking at a potential for death. But those are the common painkillers. Tramadol is in that group. I don't know that I've never told a patient that you can't get addicted on it. It just has a little better safety. It's not used rampantly and throughout because it's not that good. Is that true, Walt? It's just not that great as a painkiller. So fortunately, we don't have to deal a lot with the tramadol issue.
At the smaller doses, yeah, you don't tend to get the euphoria with it.
Yes.
But at the higher doses, you definitely
Yes.
do. Yeah.
And so it's not surfacing as a real problem that it had to deal with in a death so far. It could happen down the line.
I have a question.
But thank you.
What would be the most commonly prescribed medications for pain management that's not opiate-based? Are there many? Are they effective?
Well, and they advertise as painkillers, and that's all of your non-steroid anti-inflammatories. The beauty of them, they're really getting to the heart of the problem, an irritated nerve or a smashed toe or something like that. And that's our Aleve, our ibuprofen, and that would be, and they do, but they will alleviate your pain, and they help and are adequate for many people with injuries or whatever. They'll take care of the pain. They have side effects, and they have to be cautiously used, and even at the regular doses, they have the potential for irritation of the digestive tract and even a potential for bleed, and they're very hard on the kidneys. But they wouldn't be abused for pain because you get the other problems would surface with them if you overuse those. But even at their recommended doses, they're a little tricky. We have to be careful with them.
And there are other ways of dealing with pain. There are other things doctors can do. There are these TENS units, which are the electronic stimulation units that are effective dealing with pain. There's physical therapy. Even cognitive behavioral therapy can teach you to live and not have your life compromised by certain levels of pain. There's a difference between pain and suffering. And they found that certain kinds of counseling can also have a big impact. So it doesn't always have to be a pill. It doesn't have to be something that you're taking. Acupuncture sometimes can be effective. There are a number of different ways of addressing pain, and some, as the coroner said, is really go more to the root causes rather than just suppressing the symptom.
Even acupuncture.
Yeah, acupuncture. Sure. Can I add a couple other? They are using some of the antidepressants like Cymbalta, Elavil, and they can be helpful with some pains too, and some of the neuropathic pains too. Yeah, Neurontin. So we have to watch Neurontin now because we're starting to feel Neurontin can be very addictive too. So it's also, you have to be careful with the medication Neurontin. And the antidepressants work by blocking or inhibiting the pain sensation getting up to the brain. And so they're always worth a try. And I agree with these doctors over here that when we have a chronic benign pain situation, we cannot use opiates because it's going to be a disaster. And that's what we have to really educate doctors on more and more, is how they can treat chronic benign pain in ways. And I don't know if we have any in this state, but some of the states already have non-opiate pain clinics where they work with a lot of those techniques, everything that we've talked about here today, trying to stay away from the opiates because that's usually a one-way street.
Another interesting footnote to this part of the conversation is in the same period of time that you were talking about from 99 to 2010 with the 89% increase, I think you said 89% increase in opioid analgesics, the non-opioid analgesics, the NSAIDs and the others, actually were prescribed a little bit less in that same period of time. So there was a reaction towards the opioid pain medications and away from the non-opioid pain medications.
And a lot
Okay,
of times,
we're going to move on to
Okay.
the next question for Elaine Stano. How is heroin related to prescription drugs?
Hello. Before I answer the question, I want to thank Mr. Tennis for being here. It was so refreshing to hear your understanding and insight of addiction. I truly appreciate that, and I felt very confident in knowing that you agree with a lot of what we talk about with addiction. So, thank you. Okay. Heroin and pain pills. I think it's not a secret now that we have shown that a lot of people are being introduced to heroin because they were first introduced to pain pills, and because the cost of pain pills are so exorbitant on the street, and there's some very good marketing people out there for heroin, and heroin has gone down in price. I think it's just common sense to anybody who's addicted that if I can save myself a few $100s using heroin as opposed to pain pills, well, then that's just what I'm going to do. I think also the idea that heroin doesn't have to be injected, although that is something that every addict I think I've ever met has stated, I never use IV. The fact that you can snort it has given it a lot more acceptability among people. What prescription pain pills have also done for heroin is it's developed a new market. Because in the past, most of the time, heroin, because it is an illegal drug, is only really used among people who are looking for illegal drugs. Now you have individuals who have a bona fide addiction to an opiate, and they want relief, and so now maybe some of the coworkers that they have been introduced to heroin to help them with their pain, and they see nothing wrong with it. So I agree with Mr. Tennis. The idea that the prescription drugs are not as dangerous as heroin still holds true, and the difference between people now who come in with opiate addictions is that we start to see people that are more middle-aged, people that are working people, people that have never really thought about using a chemical to get high. They were introduced that chemical to aid them with a problem. And when they found themselves addicted, they found very few places they could go for help. Because most of the time, in the medical community, when you become addicted, they do not want to continue to treat you. Thus, you have to find another way in order to get help. And sometimes that does result in buying something off of the street. So prescription painkillers has helped the heroin usage in our country right now.
Okay, thank you very much. Our next question is for Dr. Woolhandler. What is addiction?
why does Dr. Riley get all the easy questions? Well, okay, addiction is a lot. I mean, it's like we could talk for hours on what addiction is, but I'm going to sort of give you 3 or 4 ideas about what addiction is. One of the best definitions I've heard of, and I remember this, I don't know if people are not familiar with this, they're called the Joe and Charlie tapes, or 12-step tapes, and they described addiction in there as once you start, you can't stop. Once you stop, you can't stop restarting, and you get into that cycle. And that is one of the best definitions I've ever heard of addiction. If you read some of Dr. Torsky's books, he uses a very simple definition. He said addiction is the use of drugs in spite of negative consequences. So if someone drinks, loses their job, and they continue to drink, got to be addiction. The other thing he talks about a lot about is addiction is a sort of a disease of escapism, leaving reality. And all the therapy we do is mostly having people learn to deal with reality. And it's not easy to have to hug reality day after day and deal with it. We were just working with 2 or 3 people today that were just really struggling with their early recovery because they're dealing with things they just didn't deal with. They would just get high and move on to the next drug. But if we get down to if you want to look at the physiological level, when I write the diagnosis on someone's chart as like opiate dependence, that means 2 things. One, they are physically dependent, and by physically dependent, I mean that when they stop using the opiate, they'll have physical withdrawal symptoms. Because we all know those: nervousness, running bowels, anxiety, restless legs, all over the place. So when you give a drug to someone and it produces an effect, opiates actually produce the opposite effects. They're constipating, they produce euphoria, they calm a person. When they stop it, the opposite happens. And that goes with any drug. You want to look at any drug that's addicting. Whatever it does for you when you get high, the opposite will happen to you when you stop the drug. So that's the physical dependence part. And you can have that and not be an addict, because you have to have the other part, which is the psychological dependence. And that's a key one. That's when people have the cravings. They are unable to stop using. They are able to stop, but they can't stop restarting. And the cravings and the triggers are powerful. They'll be clean for 2 or 3 weeks, and they see a friend across the street they used to get high with, and bingo, there's this tremendous craving to use opiates. So that you have to have both parts. That's the pure definition. I still like the one Joe and Charlie say, because it's down to earth, simple. Once you start, you can't stop. Once you stop, you can't stop restarting.
Okay, thank you very much. We're going to go back to Elaine for the next question. What does an addict look like, and what's the difference between the stereotypes and the reality?
Well, what does an addict look like? All you have to do is look to the person beside you. That's what an addict looks like, just like everybody else. I think there is those stereotypes that depicts the addict as the person who is slovenly dressed, or the person who is filled with tattoos and has all kind of piercings everywhere. And these are the person who, or the people who don't hold down jobs, and they don't really have any respect in the community. And they're people who just have no value system at all. And we know now, in working with a lot of the people that we work with, they're like you and me. They are just like you and me. They got caught off guard with addiction. I know the forum is about prescription drug use, but let me just say that in the years that I've worked, my working with addicts was always generally with people who their intention was to get high. That's how they ended up in treatment. They wanted to get high, their brain clicked, they ended up addicted. But now we see a lot more people who did not start out with an addiction because they wanted to get high. And that is a big, big difference between the addictions that we see now with opiates and those that we saw with heroin. These individuals live in shame and guilt every day of their life because they don't understand how they ended up with an addiction when they were just doing what they were told to do. So if you want, again, you want to identify who the addict is, it's anybody who allows themselves or who's prescribed a mood-altering drug, who does not pay attention to how often and how long they're using it. That is who the addict is today.
Okay, well, thank you very much.
Just one comment I want to make. I think Elaine hit the nail on the head. It's very easy to become addicted. You know, and I've learned this years in law enforcement, and I see the people out on the streets, And, you know, if there's one message that we can get across to young people, is to try to teach them, number one, how easy it is to get addicted, and number two, what happens to you after you're addicted. And, you know, we see a person, and we talked a little bit about the path from the prescription pills to the heroin. Let me just tell you, that's a very short path. Because very oftentimes we see a person, you know, they might get arrested for prescription pills. Next thing you know, not long afterwards, you know, we're arresting them again for heroin. It is a very short path. And what people are looking for, you know, they got that first high. Then from that point on, it's always seeking, okay, how can I get high? What is the next high? And that always leads to the heroines.
Let me add one more piece to that. And I kind of got most of my education learning from folks in recovery who've really been through, and that's, I think, they're my best educators. What I've heard over and over is how that first high was something you wanted to go back after to get, and it was this euphoria, this wonderful feeling. But the whole thing kind of just keeps ratcheting down, and pretty soon you just don't get that euphoria anymore. All you can do is avoid being sick. So you're either really, really sick, and now you're using just to get back to normal. And the whole thing, it just kind of ratchets down, and it's just kind of it seems like people, and actually suicide rate, unfortunately, is very, very high among individuals who don't get, it's overdoses or suicides, basically, pretty much. And it's because life just gets to be so miserable, I think, after time.
May I say something? You're correct. In the beginning, in the development of an addiction, it is about trying to trump the first high. But please understand that once you are in the addiction, it is totally different. Because addiction is a relationship. And I don't think most people understand that. They think addiction is I take a pill and I get a good feeling. But you talk to any addict and they'll tell you they ain't feeling so good. It becomes a way of life. It becomes what they live and breathe for and live with all the time. It is not the high anymore. Once the addiction sets in, it is not about being high. It's about learning how to function day by day the best way you know how now with an addicted brain.
Is there time
Okay.
for me to make one quick comment on this? Yes. I just wanted to repeat something Dr. Woolhandler said, that the idea of addiction to the point where it creates significant problems in one's life is very significant, because, I mean, you can be addicted to caffeine, but I've been to several rehabs and I've never been in rehab with anybody who was there for caffeine. So that is kind of a point of differentiation where technically a caffeine addict is an addict, but you know, their life is not affected by that immediately. So that is a very significant quality of, you know, addicts who go to rehabs.
Okay.
Real quick.
Okay.
Okay.
10 seconds.
I want to just mention a little bit about the initial high. We think that's part of the brain chemistry, that not everyone experiences that, but the person that's probably going to go on to be an addict is the one that's going to experience that tremendous euphoria. And like you said, they'll be chasing that sometimes the rest of their lives. But that seems to be part of the, I didn't get a chance to talk about that in my part, left it out, but about the brain chemistry being, there is a brain chemistry difference in the addicted person and the non-addicted person. And so I'm not going to go into much more of it because we've got time factors here. Thanks for that.
Okay, thank you very much. We're going to move on to the next question. This will be for Dr. Riley. How big of a problem is heroin in Fayette County?
At the present moment, there's not a surge of heroin here. We're seeing mostly the overdosing on and overuse of the prescription drugs when it turns out to be a death. It's still worth knowing where the surges are, because if it's the illicit drug source, then we can gear up and alert the investigatory agencies and the drug task force to interdict and so intercept and do what they can. On the other hand, if this surge comes in the prescription medications, then as we're now alerted, that we have to look at it from what can be done from the source of the prescription drugs. So the surges will come and go, and I can predict fairly accurately that where the surge at present is the prescription drugs because of accessibility. There's plenty of them out there. They're not inordinately expensive. When that's either supply or the expense goes up, the surge will be to heroin, which is stunningly inexpensive, and multiple doses that can be secured for a minimum amount of medication. The one aspect that, out of fairness, you ought to consider is that almost in the celebration, prescription drugs have outnumbered the number of deaths from illicit drug sources. Well, where do prescription drugs come from? Well, they come from the doctors. Well, then the doctors must have got us into this pickle, and now we'll better get after the doctors and get them to fix the pickle. And whether it's by mandating how they should manage their treatment, or whether they go to additional education, which is certainly available. There are online programs, there's mandated courses, and they're getting even to the down to the level of the med students. So, but you have to consider not me as coroner, but as a practicing physician, take for a moment and think about this. You walk into that office, there is a measurement in your body that I cannot measure practically and fix. Your lipids, we can get those fixed in a couple months. Your magnesium level, your blood sugar, we can get that fixed. If Walt comes into it and he dropped a 16-pound bowling ball on his toe and he has big alligator tears coming out his eyes, I haven't the foggiest idea how much pain he has. I know mine, if it was my bowling ball, it's the worst pain in the world imaginable. My toe, I have no idea how much. We have to take, the physician has to take it at face value and as cautiously possible treat the pain. If Walt came in because he spilled his charcoal lighter on him and has half the skin burned off his body, would you want something for pain, Walt? Yeah, and in 3 days in an ICU unit, he can be addicted to IV morphine or whatever we use because it's in the system 24 hours at massive doses and all, and now we have a major problem and he has to be weaned. So consider, pain is a real thing, unmeasurable by anything. We had mood rings trying to measure pain. West Virginia University had forehead patches. We can't tell when you come through that door, and we want to do the best we can in the most cautious way we can. Can we legislate accurate medical care? You can't legislate how well I treat your lipids and what I use for you. So give us a little bit of sympathy on this, that the surge is now, it's the big thing is the prescription meds must be traceable to the docs. They should be helping us fix it. It's not quite that neat an issue.
Well, let me just advertise our prescribing guidelines, and these are guidelines. In Ohio, they have a prescription monitoring program in Ohio, and they implemented their Ohio prescribing guidelines 12 months ago. The number of hits on the prescription monitoring program went up 8-fold in 12 months. Just raising the level of consciousness, teaching doctors certain basic things like, do you have a history of addiction? Do you have a family history of addiction? Certain areas, even if we have the prescription monitoring program, the doctors will be able to check and see if the person's doctor shopping from one place. The other thing that I think was mentioned aptly is we need to increase training in addiction in our medical schools. And we have the good fortune of having a very strong federal regional director of this SAMHSA, the Substance Abuse Mental Health Services Administration. And I'm going to get the chance to meet with the deans of the medical schools in Pennsylvania to try to push hard. There's only one medical school in all of Pennsylvania that has a mandatory course on addiction, University of Pennsylvania. None others have it. And many doctors, when somebody comes in, like one of the things I don't want to see with the prescription monitoring program is if somebody comes into my office engaging in drug-seeking behavior, if I just point to them and say, get the hell out of my office. Because if that happens, if everybody does that, then they're going to turn to heroin, because these are people that are suffering from addiction. Our doctors need to know how to screen and how to refer somebody to specialty care. They can work with it. You've got a one of the best SCAs in the state here with Jana Kyle. You need to know, the doctors here need to know where to refer somebody. If they're not an addiction doctor like you are, they need to know where to refer somebody to specialty care, to how to get them the help they need. Most doctors just don't know what to do.
Yeah, and you're right, because it's incredible that there's only one school that has one course that's mandatory, and when those doctors go out into practice, 10 to 15% of the people through their office every day are going to be drug addicts, alcoholics, or potentially on the way to that. When I ask doctors a lot, I don't see any addicts in my practice because they don't know how to look for it. You know what I mean?
They don't
It's sort of
know,
like-
they don't know them when they see them.
Exactly. So it's sort of like back to that basic education for physicians, which has been minimal. So like you said, they go the other way. They just try to get rid of them, avoid them, dodge them because they're going to be trouble and they steal scripts. Also, they never get either diagnosed, or if it's suspected, they just get shoved out. So
So
Good
imagine a
point.
disease that affects 10% of the population, 1 out of 4 families, and we don't even have a course in it
yeah,
in virtually every medical school in the nation. So one of the things, I came out of the criminal justice system. Coming into this world of drug and alcohol addiction policy, I feel like I've entered this Alice in Wonderland world where we just don't seem to be able to think straight for the life of us. This is another example where we just don't take the necessary steps, and I will continue to push on this. This is, to me, this is another example of like low-hanging fruit. Let's teach our doctors enough so that they know what to do with our individuals. Doctors, I know, get frustrated. I've asked them, why do you get so mad about when you do have somebody doing this? And basically, Dr. Matt Herford, who works in drug and alcohol issues in Philadelphia, said, doctors are trained to solve problems. We don't know how to solve this problem, so we just want them to go away. Just get out. So we need to teach them how to solve the problem.
I would like to, briefly add to that. With the difference between heroin and the prescription drugs, there's a very distinct difference, and I think it's important to highlight it, and it's important to have panels like this and talk about the prescription drug problem, because in these numbers are from the CDC from 2010. Of the 38,000 drug overdose deaths in the United States in 2010, 60% were related to pharmaceuticals. Here's the thing. The reason why the pharmaceuticals are almost, in a way, more insidious than heroin is because of, number one, they're plentiful, they're cheaply made, they're safe. In the mind of a drug addict, you would much rather, trust me, take something out of a pill that has somebody's name on it that was prescribed by a doctor and made by a pharmaceutical company than you would buying something in a little bag that you don't know what it is. You're also much more likely to run into pharmaceutical-grade drugs in schools than you are to find, not that you won't find heroin in schools, you will, but you're much more likely to find heroin in schools. I think when you look at the numbers, like you were talking about, the 89% increase, that is a direct correlation to the amount of prescriptions that have been written, and that, when you're talking about this, you're talking about supply-side economics. When you create a market for something where it's cheap and plentiful and easily accessed, the problem is going to follow.
I agree with that totally. And by the way, just another statistic along the line that you're talking about, prescription drug overdoses and abuse does now exceed all of the illegal street, all of them put together. But the other thing is now drug overdoses now, as a cause of death, now exceed car crashes as the leading cause of accidental death in America.
40,000 a year.
Yep.
Just to get a perspective on that, if you think about how long, and I'm not making comparisons between the reasons for the deaths, but if you think about how long we've been fighting overseas and how many people have died compared to how many people have died right here at home from drug overdoses, it's staggering difference. It's about 400,000 people in the last about 12, 14 years right here in this country.
Secretary Tennis,
Yes.
one thing I want to mention, and no one's seeming to address this right now. As pharmacists, I can tell you, drug seekers, they're sneaky. Okay?
Sure.
So they will go to a
I can
doctor,
attest to that.
I mean, and they don't. They're sneaky. I mean, and they will sell you whatever you can imagine to make you believe that they are in dire need of something. They will make a doctor believe anything, okay? Because they've been practicing. So they will go to a doctor, and a doctor is there to help that patient. That doctor, in his mind, is trying to help alleviate whatever problem that patient has. Unfortunately, the doctor doesn't know that patient A is also going to Dr. B, C, D, E, and F. Okay? We in pharmacy have been trying to push for the monitoring system for years. Right now, there are 40 states that have it, and we don't.
48.
Okay, well, now it's up to 48? Okay. So, as you can see, if they go to the monitoring and a Dr. A writes for the drug, and now all of a sudden the patient goes to Dr. B is going to see that they already went to Dr. A. Now all of a sudden, wow, now we can track it, now we can stop it. It's not just a matter of educating the doctors, it's a matter of making them aware that that patient is seeing another doctor, and you can't do that unless you have the monitoring system in place. That will be the single biggest thing that can help drug diversion, as far as I'm concerned. Being in the pharmacy on a daily basis, that gets put into place, that will help drug diversion more than anything else that I've ever seen.
And
I agree.
to follow up on that with the monitoring program, because I think that's a great program. Take it from a sneaky recovering
So
drug
I
addict.
don't mean anything by it.
No. It's well earned. Trust me. What kind of cooperation is there going to be in interstate monitoring programs? Because let me tell you something. From being in southwestern Pennsylvania, if you're watching me here, I'm driving across the border. I'm going to Ohio.
They also, Ohio, West Virginia have them, but just so you
Would
know,
they-
we're going to, the federal government's working on, and actually, I think the Senate bill that Senator Pat Vance put in has provisions in there directing us to work across with the other departments, but also the federal government's working at trying to get all of those monitoring programs speaking to each other, because absolutely,
Yeah.
you think about how much of our population, look at Philadelphia, look along here, along the west, like a huge portion of Pennsylvania's population is 40 minutes from another state, and you will cross over. Now, you're only going to be able to get two, those systems need to speak to each other. That's
Right.
the bottom line, and that's going to be something that I think is provided for in the legislation.
And I think by doing that, you're going to be able to still treat the patient who needs honest treatment without tying a doctor's hands and saying, well, now you have to watch this, 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 and this. Now they're going to be able to see it. And I think that's a huge thing.
One
for
of the
them.
great things about both the House bill that's got sent over to the Senate and the Senate bill that's starting to move is they also allow us to, the Senate bill has it in the Department of Health, which is probably the right place, but it puts us at the table so we make sure we can work with the doctors about, once you've identified the individual with the drug-seeking behavior, what are you going to do? Are you just going to say, get out? I mean, they could do that, but ultimately, I don't think that's going to, I think what we're going to do is we want to be teaching our doctors how to be as effective as possible in intervening and saying, look, you've got a problem. If you want to walk out of here, I can't stop you, but you've got a problem, and you're not going to be able to get what you're looking here, and you've got to, basically do the kind of intervention that can be as effective as possible to get them into specialty care
And
for treatment.
I think this is huge. Really
It's huge, and I think there's some, legislators are here. I believe that I'm hearing really encouraging things about that legislation moving, so I feel pretty encouraged. There was a fight, I know, between law enforcement and the medical community about basically, when I say our, I mean law enforcement's ability to get after the doctors that are really engaging at criminal levels. We need to be able to law enforcement needs to be able to get at the people that are really not practicing medicine. They're just
Pill
making
mills.
lots of money, the pill mills. And so there's a little bit of there's been a tug of war, but that issue on the Senate bill has been resolved between the Medical Society and the District Attorneys Association. So I think, there are still going to be people that are, by the way, there's one of the things you're going to hear from the ACLU, and it's just not true, is that this is going to be big government looking in on what you're getting in your prescription medicines. That is a falsity. None of the legislation has that. This allows doctors to get information about somebody that's coming in, bouncing from doctor to doctor. This is going to save thousands of lives, and there's no big government that's going to be knowing when you go get a painkiller or this. That's just not true.
Well, they're already reading our emails, so I really don't care. So it's okay.
Okay, me too.
Okay, we're going to move on to the next question, and this is for Secretary Tennis. What can the community do to prevent or reduce overdoses?
I'm going to start with another advertisement for your excellent SCA, Jana Kyle. I think the first thing I would do if I was wanted to organize my communities, I would give a call. You have a really, really strong Drug and Alcohol Commission and executive director here who can help guide you. There are a number of models. The two models I'm most familiar with that are outstanding, and you can look these up. are communities that care. This is a proven model for really doing effective work at organizing your community. There's drug-free communities. Those are strong. That's another strong model as well. So I would strongly recommend those. In terms of reducing overdoses, that's like a big priority for us. We actually started an overdose rapid response task force to get law enforcement, ambulance services, other medical providers, treatment providers, to all those silos to speak to each other in corners, to speak to each other in real time about drug trends, so that if, for example, fentanyl is popping up in your communities, we want to make sure that your police chiefs and your district attorney knows they'll send somebody in undercover and start making buys to get that stuff off the street. We also want to make sure your ambulance drivers know how to deal with whatever is the drug du jour that's popping up that's causing overdoses in your community, so that we can get them that immediate medical care that they need. I think another thing I would do, I just want to say a couple of things. I know you don't have me on the docket for naloxone, but there is legislation moving through to allow third-party prescribing for naloxone. I want to talk about what happened in Quincy, Massachusetts, and some of you may have seen this on TV, but the first Massachusetts legislature passed a law saying that police could have it. The police were reluctant in Quincy, Massachusetts. It's a city of 100,000, bad heroin problem. They were like, is this really our thing? They love it now. In the first 3 years of this pilot, they reversed 170 overdoses. The police did. 170 overdoses. Not only that, but from a policing perspective, their community police relations are probably better than anywhere in the nation. They get all kinds of information they need. I'm personally a big believer in law enforcement, so one of the things I would want any community to do is be militant about working with your local law enforcement, so that if you know somebody's dealing, if there's some kind of trafficking going on, give your police a call. This is life or death. And it's
When you
not
talk about
something
naloxone, you're talking about Narcan.
But what's that?
Narcan.
Narcan is the brand name. They have several kinds now. They just came out with one of those injector auto pen things. They're a little more expensive. In Quincy, Mass, they use the nasal sprays. Unbelievable. And you can have a dramatic impact right there. So even if you have somebody in your family, your doctor technically can't prescribe to you for a family member, but if you can get your family member to get that prescribed, I think doctors should be, if they're prescribing some of the heavier duty opioids, should be co-prescribing naloxone. Probably the nasal spray would be best, since most people don't want to use a needle, or the little ejector pen, the EpiPen. That could be good as well. But that is a surefire way, no side effects to naloxone, except for you are going through very, very rapid withdrawal. So sometimes people get agitated. The accounts of a violent reaction are overblown. I've looked at the research. It's about 4% of the cases people become pretty agitated and maybe a little bit like this. Our police officers know how to handle it, and I know our ambulance drivers do too, and they're already using it. So that's another thing I would try to, for the overdose issue specifically, I would look at. One of the things, before I wrap up, that we did with our overdose rapid response task force is we sent out a policy directive to all of our SCAs, the county drug and alcohol directors, and said, work with your emergency departments to work on a warm handoff, so that if somebody comes in and survives an overdose, we want to do the best we can in those emergency rooms to get them to treatment. Don't just give them a phone number and say, be on your way, here, call this or whatever, but try to do as robust an intervention as possible, because they'll overdose again. And many people who would die of a fatal overdose had survived prior overdoses. So that's a good opportunity to intervene. It's a crisis moment in the individual's life, which tends to be a good opportunity to intervene. We want to make sure we do that.
Okay, thank you very much. We're going to move on to the next question. This is for our Fayette County District Attorney, Jack Hennigs. What percentage of crimes would you say committed in Fayette County are drug-related?
I would say if you include alcohol in addition to drugs, probably 80% of the crimes that we prosecute in Fayette County are directly related to drugs and alcohol. I wrote a quick list, and they start with homicide, and they go down through robbery, burglary, theft. We're seeing a vast increase in retail thefts. And in fact, what they're doing is going in, stealing the items, going back, converting it into cash, going and buying drugs with it, whether it's heroin, whether it's pills, crack cocaine. That is leading the way, as a matter of fact, in crimes in Fayette County. Unfortunately, what we also see, and this is the sad part, is that we see families that are the victims of the crimes being committed by their own relatives, by their sons, by their daughters. Those are the crimes that go to the heart of the family. I think some of our earlier statements where some of those are borne by the family in secrecy for a long time. They're ashamed. They don't want to go to the police. They don't want to tell on their relatives. They don't want to see jail for them. But unfortunately, time after time, after that addict, as it turns out to be, has committed those crimes over and over again, that unfortunately they have the resort only to go to the police, and that results in the prosecution of those individuals. If you look at possession, the normal things that you think about: possession, delivery of drugs, trying to get drugs from pharmacies like Walt, those make up 10-20% of the crimes. If you look at forgeries, if you look at access device fraud, which is basically a fancy word for stealing somebody's credit card, and a lot of times it's the grandmother's credit card that's being used to go down and get money, to take money out, to take food out, to take merchandise out, again, to get money to buy drugs. If you look at the DUIs, unfortunately, they're both drug-related as well as alcohol-related DUIs. I think if you look at the breakdown between drugs and alcohol, it's probably now about 20 or 30% are drug-related, and the rest of that is alcohol-related. You look at homicide by vehicles, unfortunately, innocent victims killed by people driving a vehicle while they're high, either on drugs or alcohol. Those are, unfortunately, the vast areas that we prosecute. I have on my desk right now, unfortunately, about 8 burglaries committed by the same individual. He's 19 years old. And obviously, the reason that he committed those burglaries, very simple. He was high at the time, but he also wanted to keep being high. He wanted the heroin fix that he needed. He was up to, as I understand, a couple $100s a day. He had to steal guns, money, whatever, from individuals in this community. And unfortunately, that is repeated over and over and over again. And unfortunately, what do you do with a 19-year-old at that age that has committed those burglaries? He's going to go to a state correctional institution for a long period of time. And do I think that that's the best way to go about prosecuting someone like that? Unfortunately, it is, but is that the best for that person? No. And if we could develop, through everything that has been discussed here today, a way of getting to that addict before he becomes a criminal, that would save the taxpayers of Fayette County, the taxpayers of Pennsylvania, millions of dollars, and would save, if we were successful, the lives of those individuals before they went down the path that they had chosen to go. We have some treatment options in Fayette County. We have a day treatment center that's been established. We're trying to expand those operations, but unfortunately, our options are limited. And I think that one of the saddest things that I do as the district attorney is when somebody's on probation or parole and they come in and they've actually been given a break to go on probation, or they've been given a release from jail to go out and hopefully live a life free of crime. And 1 month, 2 months, 3 months down the road, they come before the judge because they've tested positive for a variety of drugs, alcohol, pills, heroin, crack cocaine, you name it. And what can the judge do? he has very little options at this point because the option is to send him back to jail. And unfortunately, sending him back to jail is only postponing the inevitable because once he gets out or she gets out in 6 months or 8 months, we're back to the same situation all over again. And they're still addicted. They're still going to go out and commit those crimes. We haven't at all interrupted that cycle. And my frustration, certainly from a district attorney standpoint, is not having the funding, not having the ability to send people for long-term drug and alcohol treatment. In fact, at this point, we've talked a little bit about treatment options, but right now, if I'm not mistaken, most insurance policy pays for about a 10-day drug withdrawal situation. I'm sorry, I think a guy or gal addicted to heroin or pills is not going to get healthy with 10 days. And our legislators are here, and I know that there's funding issues and all over the Commonwealth, but it really doesn't make much sense to me to pay whatever we're paying per day in the Fayette County Jail, the State Correctional Institution, when we could pay less if we had drug and alcohol facilities that would treat those individuals before they became residents of our institutions. So from my standpoint, from the district attorney's standpoint, we have to prosecute who we need to prosecute, but I wish there were better ways to do it.
Just want to respond too about I appreciate everything you said and agree. 10 days is a ridiculous amount of time for someone. It's probably enough to kill them because you're going to relapse and you're at risk of overdosing because your tolerance is down because you've been off for a while. The Act, just so you know what your rights are, if you have private health insurance, in most instances, you're covered under what's called an Act 106 benefit. That means you're entitled to a minimum of 30 days residential and 30 outpatient units, plus what are called 30 more flex units, which could be either another 30 outpatient units or 15 more residential. So it could be as much as 45 days residential. Still probably not enough for someone with a full-blown heroin addiction, but if you are dealing with the disease early on, it can be enough if you're caught soon enough. I mean, if you catch it soon enough. If you are Medicaid eligible, then you're entitled to, you are meant to get whatever you need. Now that's been an ongoing battle. I mean, we're trying to make sure that our behavioral health managed care organizations are really covering the level of treatment that you need. And that's a wrestling match, and that's something, one of the things my job to do is to meet with them, and I actually am meeting with one of their CEOs soon to try to explain that aside from the fact that you're wasting your money if you undertreat, like people, you're really, really endangering individuals by undertreating. You need to fund the level of treatment that's called for under an individualized clinical assessment, and then we have something in Pennsylvania, I think it's the best placement criteria in the nation, Pennsylvania Client Placement Criteria. We just came out with a new edition of it. We just approved it about a week ago, and we've been working on it for 2 or 3 years. Dr. Pringle from University of Pittsburgh has been overseeing that for us. It's a clinical decision. Just like if you come in with heart disease, you might be able to get better on a little exercise if we catch you early. You might need open heart surgery if you're near death. So it really depends. It's an individualized clinical assessment, and I think we have to be prepared, and you know, I come as a lawyer, so I think about it from a legal perspective. We need to be prepared to really demand that people get the level of treatment they need. And now there's a federal law called the Mental Health Parity and Addiction Equity Act, and that says we treat addiction like we treat any other disease. That doesn't mean if you get open heart surgery for heart disease that we're going to give you open heart surgery for addiction. It doesn't mean you're matching with what are called cognates. It means it's a clinical decision. You get what you need clinically. Ultimately, it's an issue that will be decided in the courts by the judges, probably by, you know, just like the Act 106 benefit was decided. So your rights to treatment are very, very strong in this state. It's why we are able to do a little better than other states do, and I really urge you to be tough about it when you're seeking treatment for yourself or a loved one.